This is Dr. Aditya Sibi Chakravarti from Dr. Talks. Today we will be dealing with systemic lupus erythematosus. As you all know, systemic lupus erythematosus is an autoimmune condition that is more common in a female of the reproductive age group. That is, female between 20 to 40 years are more commonly involved in the systemic lupus erythematosus. We will directly jump into the Sle criteria. This is the most important thing you must know in a patient with systemic lupus erythematosus. It is the diagnostic criteria. There are two components. One is the clinical manifestation, the other is the laboratory manifestation. The clinical manifestation starts with any skin findings. The skin findings can be three things: acute, subacute or chronic. If any one of the three findings is present, that is the first point. Second one, he will have evidence of oral or nasal ulcers. Third one will be the evidence of non-scarring alopecia or scarring alopecia can be done. That is the third point. The fourth point will be evidence of any serositis or evidence of any serositis in the form of pleuritis, pericarditis. These are the serositis. Or there can be evidence of synovitis, more than two joints. Synovitis means inflammation of the joints, can have wrist pain, knee pain, joint pains. These findings can be there. Or the patient can have evidence of renal involvement in the form of increased protein creatinine ratio more than 0.5, or in the form of RBC cast in urine, or in the form of any abnormal renal biopsy. And the CNS findings in the form of depression, psychosis, acute confusional state, presence of cranial neuropathy or peripheral neuropathy or myelitis, anything. This is the CNS manifestation. Finally, the presence of anemia, leukopenia, lymphopenia or thrombocytopenia. This is the major clinical criteria. And then the lab criteria in the form of positive ANA antibodies, or in the presence of positive anti-dsDNA, or presence of anti-Smith antibody or anti-phospholipid antibody, any of the three, lupus anticoagulant or a beta-2-glycoprotein or anticardiolipin, any one of the three can be taken into account. Then the other findings will be a low serum complement. The patient can have low C3, low C4 and low CH50. This can be present, or the presence of direct Coombs test. In the absence of any hemolytic anemia, there can be evidence of positive direct Coombs test. A presence of four positive criteria, one in each group, has to be taken as significant. However, if the patient is having a renal biopsy finding of a glomerulonephritis, of lupus nephritis, then just one of the antibodies can make them diagnosis. You need to have 4 points. So what are the autoantibodies? The autoantibodies, namely the ANA, the anti-nuclear antibody. This is the most commonly done routine screening activity. It is positive in more than 90% of patients with systemic lupus erythematosus. So ANA is the first point. The second antibody is the anti-dsDNA. This anti-double stranded DNA, it is the most sensitive antibody, 70% sensitivity for diagnosing a patient with systemic lupus erythematosus. It not only diagnoses the patient, it can also mean if the patient is having higher incidence like lupus nephritis or vasculitis. If those are present, you have to think in terms of ANA involvement. This anti-dsDNA should be done with indirect immunofluorescence. That will be better than ELISA method. The third one will be the anti-Smith antibody. The anti-Smith antibody is the most specific for lupus, but it is not sensitive. Only 30% sensitivity is present for systemic lupus erythematosus. So what other antibodies? The presence of anti-ribosomal P antibody. This anti-ribosomal P antibody indicates CNS lupus. There are two, either psychosis or depression. That type of CNS lupus seen with anti-ribosomal P antibody. Then anti-neuronal or anti-glutamate antibody. This also indicates the presence of active CNS lupus. Then anti-RBC antibody, anti-erythrocyte antibody, form of autoimmune hemolytic anemia. Anti-platelet antibody in the form of immune thrombocytopenic purpura, or anti-U1RNP. That indicates an multisystem connective tissue disorder, MCTD, that is positive in anti-U1RNP. Then what other antibodies? This sums up the major group of antibodies that is positive in SLE. The other atypical antibodies will be the anti-histone antibody that is positive in drug-induced lupus erythematosus, and the presence of anti-Rho or anti-La antibody that is positive in a patient with congenital lupus in the form of heart block or in the patients with, they have just less chance of nephritis. The anti-Rho and anti-lab patients have got less chance of nephritis. So what happens pathologically? If you go for a renal biopsy, you will find the grading of lupus nephritis. This is the most important grading of lupus nephritis. So first one will be the, you have to go for either with the help of light microscopy as well as immunofluorescence. If the light microscopy appears, the glomerulus appears normal and immunofluorescence shows mesangial deposits, we can diagnose that minimal mesangial or class 1 lupus nephritis. The class 2 lupus nephritis means mesangioproliferative lupus nephritis. There can be mesangial matrix expansion or proliferation of mesangial cells in light microscope, and with immunofluorescence there will be antigen antibody complex deposition in the mesangium. This is class 2 or mesangioproliferative lupus nephritis. Then class 3 will be the focal lupus nephritis. There will be focal deposition of the immune complex in the subendothelial region. This focal means less than 50% of the glomerulus can be involved. The glomerulus which are involved can have either endocapillary proliferation or extracapillary proliferation. They can have active lesion or they can have inactive lesion, a focal lesion or a global lesion. Anything is possible. We use the term A for active lesion, that is a proliferative lesion, or the term C for a chronic lesion, that is a sclerosing lesion. This is type 3 lupus nephritis. The type 4 lupus nephritis means diffuse lupus nephritis. In the diffuse lupus nephritis, there is diffuse subendothelial deposition. More than 50% of the glomerulus can be involved. This is again, this can be either active or inactive. This can be either intracapillary hypercellularity and extracapillary hypercellularity. Anything of this is possible. Class 5. Class 5 involves membranous lupus nephritis. What is membranous lupus nephritis? This is contributes thickening of the, there will be extra capillary deposition. There will be the subepithelial deposition. The thickening of the membrane will be seen. There will be subepithelial deposition of the antigen antibody complex. This class 5 lupus nephritis can have findings of class 2, class 3 or class 4 lupus nephritis. Class 3 or class 4. Both this. Class 5 lupus nephritis is also called as the membranous lupus nephritis. In this class 5, there is subepithelial collection of in the immune complex. This subepithelial immune collection can have also findings of class 3 and class 4. That indicates it's a proliferative glomerulonephritis. And the class 6 means advanced sclerotic. More than 90% of the glomerulus will go for glomerular sclerosis. So this is the renal pathology biopsy classification of lupus. Then what they will have a biopsy of a blood vessel can show evidence of vasculitis because of antigen antibody immune complex deposition. Leukocytoclastic vasculitis is the most common type, and presence of vasculitis means there is high disease activity and in need for higher intervention. And a skin biopsy can show the presence of immunoglobulin at the dermoepidermal junction, and there can be evidence of T cell inflammation, inflammatory cell infiltration, the dermoepidermal junction surrounding the dermal appendages. They can be infiltrated. And the lymph node biopsy shows non-specific chronic inflammatory lesion. This lymph node is done to rule out other malignancies or infection. So going into the symptomatology, what are the general symptoms? The patient can have evidence of fever, malaise, fatigue, weight loss, anorexia. All these findings can be seen in almost all the patients with SLE. So what are the musculoskeletal symptoms? The musculoskeletal symptom, the first one will be the myositis. Myositis is evidenced by clinically the patient will have weakness. If you go for a CKMB, enzyme will be elevated. An MRI can identify the inflammations, and biopsy shows muscle inflammation. So myositis can be a finding. Or the patient can have non-specific muscle pain. This muscle pain can be secondary to either the steroids which we use in the treatment, or secondary to other drugs which are being used in the treatment of rheumatoid arthritis. Or the patient can have bone pain. The patient can have non-erosive upper limb predominant distal symmetric arthritis. There should be non-erosive, bone erosions will be absent. This basically involves the wrist joint and the knee joint and other small joints of the hand. There will be pain with swelling, with redness, with tenderness. All the findings will be present in predominantly in the wrist joint, but the X-ray shows non-erosion. The most important differential diagnosis for this arthritis is if the patients on long-term steroid therapy can go for ischemic necrosis of the bone. That can also produce bone pain. This arthritis requires high-dose steroids, and ischemic necrosis of the bone requires avoidance of steroids. So it is important to differentiate these two conditions. So skin manifestations. There are three groups of skin manifestations, one for acute, one for subacute, one for chronic. The chronic skin manifestation is called as the discoid lupus erythematosus. This discoid lupus erythematosus can involve the face, it can cause disfiguration of the face, and it can also involve the scalp, causing alopecia. This discoid lupus erythematosus will have a circular raised lesion. There will be hyperpigmentation and erythema towards the periphery, and in the center there will be fibrosis, and there will be destruction of the dermal appendages in the central region. So this is called as the discoid lupus erythematosus. It is a pre-malignant condition. Then acute condition can present, acute skin can be a malar rash. Malar rash can involve the bilateral cheek and the nasal bridge. There will be sparing of the nasolabial fold. The patient will have erythematous, highly photosensitive, raised lesion with scaling will be present. This is the acute manifestation. Subacute manifestation can have a psoriasiform pattern. They can involve in the forearm can be involved. Psoriasiform pattern of involvement can be present. They have got anti-Rho antibodies are positive, and they are also highly photosensitive. So what else you can do? You can also have lupus paniculitis or lupus verrucous. There can be vegetation. Lupus profundus also called as paniculitis, and other hypertrophic form of lupus is also present, and lichen planus-like lesion is also seen. So the renal involvement. As we say, nephritis and other infection are the most common cause of death in a patient with SLE in his first 10 years of life. So it is important to pick up nephritis and treat it aggressively. How can you pick up the nephritis? Majority of the SLE patient will not be asymptomatic in a nephritis patient. So you have to go for two investigations. One is the urine routine. If the urine routine shows significant hematuria and proteinuria, and if there is other clinical signs of flaring up like high anti-dsDNA, low C3, C4 levels, then you have to go for renal biopsy. Because only with biopsy, if it comes as class 3 or class 4, or sometimes class 5 with the finding of class 3 and class 4, that indicates there can be a diffuse proliferative glomerulonephritis. In that case, you have to go for high-grade aggressive treatment. If it is a class 1 or class 2 lesion, or if there is a class 6 lesion, then you need not go with such aggressive treatments. But if it is a class 3 or class 4, you have to go for aggressive treatment. Otherwise, the patient will go for very rapidly develop into CKD, and other hypertension and other complications will be occurring. Then CNS manifestation. The most common CNS manifestation is the cognitive dysfunction. There will be memory loss, there can be poor reasoning. This is the most common finding. The other findings include severe headache. Severe headache can be a sign of flaring up of disease, and there can be evidence of acute confusion. The patient can have psychosis or depression. This psychosis should be differentiated from steroid-induced psychosis. Steroid-induced psychosis usually present within the first week of starting steroids, and usually will be secondary to high-dose steroids, high-dose prednisolone 40 milligram, and it recovers after discontinuation of steroids, so that should be recommended. And seizures of any type can occur in SLE patients. The other findings are peripheral neuropathy, cranial neuropathies, everything is possible. Myelitis is a dreaded complication, and we will go for high-dose steroids to suppress myelitis. So what are the vascular manifestations? SLE patients are at high risk of developing TIA and stroke. This is because of two reasons. One, because of vasculitis, and second, because of the higher thrombosis. This high thrombosis is hypercoagulable condition is because of secondary to APLA syndrome. Patients with antibodies against the phospholipid antigen, they have got a high hypercoagulable condition. They will have high PT0, APDT. They can easily form blood clots with the carotid artery, or it can be secondary to the Lieben's-Zipf's endocarditis. From there, embolic can go up, or it can be secondary to vasculitis. So patient can present as TA or stroke or myocardial infarction. Myocardial infarction is one of the most common cause of death in SLE patient. Myocardial infarction occurs because of accelerated atherosclerosis, plus some vasculitis and hypercoagulable condition also contribute to it. Who are all the patients who are high risk of developing accelerated atherosclerosis and death from myocardial infarction? Elderly male who is diabetic, hypertensive, dyslipidemic, who has got a high homocysteine level and high dose of steroid for disease suppression, and high lipid levels. LDL levels, these patients are highly notorious to go in for ACS events. You have to treat both with anticoagulation for anticoagulation for Aplar syndrome and also high dose steroids to suppress the inflammation. A steroid anticoagulant combination should be given in these patients. Now, what are the cardiac complications? Most common cardiac complication will be the pericarditis with pericardial effusion. This rarely goes for pericardial tamponade, but it can be managed with steroids or NSAIDs. Then the other complications would be then myocarditis and endocarditis. Endocarditis in the form of Lippmann-Sachs endocarditis. The unique finding of this Lippmann-Sachs endocarditis is that it can involve both upper and below, both the side of the leaflets can be involved in Lippmann-Sachs endocarditis. That is the unique finding of Lippmann-Sachs endocarditis. Then the patient can have acute onset mitral regurgitation, or the patient can have accelerated atherosclerosis, MI, and congestive cardiac failure, and patient can develop arrhythmias. So you have to manage everything. You should reduce the inflammation with anti-inflammatory agents, along with routine CCF management, arrhythmia management, or ACS management should also be given in such patients. Pulmonary manifestation, pleuritis with pleural effusion is the most common manifestation, will respond to NSAIDs or steroids, or acute lupus pneumonitis. There can be acute infiltration of the lung parenchyma can be present, or it can present as diffuse alveolar hemorrhage like picture is also possible, or the patient can have interstitial inflammation, interstitial fibrosis, and shrinking lung syndrome. There can be restrictive lung disease, some ventilated defect with the diaphragmatic defect can be present in shrinking lung syndrome patients. Also, the patient can have evidence of pulmonary artery hypertension. So, what are the blood manifestation? Most important manifestation will be the anemia. This anemia can be two reasons, either anemia of chronic disease or anemia secondary to hemolysis. This hemolysis is secondary to autoimmune hemolytic anemia. Then the patient can also have findings of lymphopenia and leukopenia. The granulocyte count will be normal, so there won't be any chance of increased infections. But there is leukopenia and lymphopenia, and there will be thrombocytopenia. This thrombocytopenia, it can be recurrent and refractory. If the first episode of thrombocytopenia, you can manage with steroids. But if there is recurrent thrombocytopenia with a low platelet less than 40,000, or the patient have evidence of bleeding, then you have to go for other management like rituximab, splenectomy, high dose steroids, they should be given. Then GI manifestation, two GI manifestation in the form of autoimmune peritonitis. Autoimmune peritonitis can manifest as abdominal pain, nausea, vomiting, diarrhea, or the patient can have vasculitis. Vasculitis in the form of GI bleeding, perforation, or raised AST, ALT levels. These findings require aggressive high dose steroids if you have these findings. The eye findings, what are the eye findings? There can be either non-specific conjunctivitis or a cephalic dry eyes can be present, or serious manifestations like optic neuritis, retinal vasculitis, and if the patient can also go in for blindness, everything is possible. You also have to go for high dose steroids to suppress this defective functions. So what happens in SLE? Why does SLE manifest? We haven't clearly got the pathogenesis of SLE completely, but there are certain genetic risk factors such as deficiency of early complementary components, then TREX gene mutation, then certain HLA-DR2 and DR3 patients. These are highly susceptible patients, and there are certain noted environmental risk factors like patient exposed to ultraviolet radiations, or patients exposed to oral contraceptive pills, female sex, and patients having infected with the Epstein-Barr virus, inhalational silica inhalation, those patients, cigarette smoking, these are all risk factors. Alcohol consumption is found to be protective against SLE, but we are not sure about how it is. And there are some histone demodification, then DNA hypermethylation, histone modification. This epigenetic modulation can also play a significant role. All these things can result in increased destruction of immune cells and reduced clearance of those remnants. This results in the formation of autoantibodies because of the antigen presenting cells releasing the interferon alpha, leading to T cell activation, predominantly Th2 activation, release of interleukins 4, 5, 13, activation of B cell, and resulting in formation of antigen antibody complex. This antigen antibody complex are deposited in all the tissues of the body, leading to the various manifestations. This is one of the most discussed pathogenesis. Some genetic risk factor plus environmental risk factor, they go for abnormal immune response goes in for systemic inflammation and end organ damage. This is the pathogenesis. So how do you diagnose a patient with SLE? First, the patient should have the SLE criteria. The SLE criteria should be more than 4. If the patient is having more than 4 with 1 clinical criteria and 1 lab criteria, must be a must. Then you can diagnose with 93% sensitivity, 92% specificity SLE. Other routine antibodies should be positive. The patient ANA must be positive in more than 90% of the patient. Anti-DS DNA should be positive in 70% of the patient. A patient with high anti-DS DNA, low C3, low C4 indicates the patient has got high disease activity and there is high involvement of chance of nephritis or vasculitis, and such patient requires aggressive steroid and immunosuppression. The other antibodies were what we mentioned earlier, that all the antibody profile, the extended nuclear antibody profile should be done to detect what the antigen is present. Then what are the other investigations? There are certain investigations which are used in the follow-up of the patients. Say you have to go for urine routine. Patient with SLE diagnosed to be SLE and started on steroids, comes back to you 1 or 2 months later with a urine routine report showing significant proteinuria and hematuria. Then you have to think of relapse. And other investigations will be a progressive anemia and a high dsDNA levels, a low C3, low C4 levels, or patient with a low platelet count. All this means that patient is going for flaring up. Any patient with signs of severe headache, worsening rashes, and patient with worsening renal function, decrease in urine output and increase in urea creatinine levels, these patients are high risk of going in for flaring up, and they should be immediately picked up and start on aggressive immunosuppressive therapy. There are special situations which are associated with SLE patients. The first one will be the APLA syndrome. So any young female presenting with recurrent pregnancy loss with evidence of arterial thrombosis or venous thrombosis with the presence of one of the 3 antibodies, an anti-lupus anticoagulant antibody which is diagnosed by dilute Russell venom by PET test, or a patient having an anti-beta-2 glycoprotein antibody or an anti-cardiolipin antibody. One of the 3 should be RPR positive. One of this will be positive with the clinical evidence of thrombosis or clinical evidence of arterial venous thrombosis with thrombocytopenia with lab profile. You can think in terms of APLA syndrome, and you have to manage the patient with appropriately. If it is a pregnant female, she must be administered heparin with aspirin right throughout her pregnancy to prevent recurrent pregnancy loss. Or if it's a non-pregnant female, you can go for warfarin with a PTNR of 2.5 to 3.5. If it is the first episode of thrombosis, if there is recurrent thrombosis, warfarin with the PTNR of 3 to 3.5 should be maintained. Severe anticoagulation is required. Lifelong anticoagulation is also required in such patients. Then pregnancy. Pregnancy patients the point with pregnancy is that the choice of drugs differs from other conditions. A pregnant patient with a flare-up of SLE can be managed either with hydroxychloroquine combined with low-dose prednisolone. Raising the dose of prednisolone can have fetal abnormal properties because baby can have low IQ, the baby can have patient go for increased development of when he goes into adulthood, he can go for obesity. Other patient can go for adrenal suppression in the baby. All these complications are possible when you go for hydrosteroids. So you have to go for risk-benefit balance. So steroids can be given, hydroxychloroquine can be given, or you can go for azathioprine that can also be given in pregnant female. The other problem during pregnancy is that the APLA syndrome. APLA syndrome can lead to recurrent pregnancy loss. It has to be managed with heparin and aspirin in pregnancy. This is the pregnancy problem. Then other condition is the HUS-TTP. There is increased incidence of hemolytic uremic syndrome and thrombotic thrombocytic purpura. These are basically the small vessel vasculitis in kidney and brain respectively. They can present as anemia and renal failure in the form of raised urea creatinine and thrombocytopenia. With there will be formation of microvascular clots in the small blood vessels with evidence of schistiocytes in peripheral blood smear with the raised LDH level. Raised LDH level, schistiocytes, anemia, renal failure, thrombocytopenia. Following a pneumonia or diarrhea, you have to think in terms of HUS or TTP. This has to be managed with plasmapheresis or IVIG. Steroids can also be tried, but with very poor results. Then drug-induced lupus. This is a unique group of condition. It is very unique because it is more commonly seen in white population. Basically, SLE is more commonly seen in Afro-American and Hispanic population. Drug-induced lupus is more common in white population. SLE is more common in females. DLE is more common in male population. Then this patient can present with fever, myalgia. There can be serositis and synovitis. Polyserositis and synovitis can be present. But renal and vascular involvement and vasculitis will be absent in drug-induced lupus. Anti-histone antibodies will be positive, and ANA can also be positive in some cases. This patient can occur secondary to drugs like sulfonamides, hydralazine, isoniazid, procainamide. All these and a variety of other drugs can result in drug-induced lupus erythematosus, especially in white male populations. And coming to treatment, basically before treating, we have diagnosed a patient based on ANA positive with the classical clinical symptoms with a SLIC score of more than 4. You have diagnosed as SLE. Then we have to go whether the patient is having any major organ involvement or there is no major organ involvement. When there is no major organ involvement, then you have to go for how is activity of daily living. If there is a poor activity of daily living, you have to go for steroids and belimumab. If there is good activity of daily living in a patient who has got no life-threatening organ involvement, you have to go for conservative management. So, diagnose SLE patient with serious organ involvement, without serious organ involvement. If there is no serious organ involvement, then the patient's activity of daily living, good activity of daily living, conservative management. Poor activity of daily living, you have to go for steroids and belimumab. So, how do you manage this non-life-threatening illness first? If the patient is having complaints like fever, fatigue, myalgia, arthralgia, with ANA positivity and anti-DNA positivity, you have to first manage with them NSAIDs. NSAIDs, the problem with this NSAID is that there are two problems, especially in SLE patient. Use of NSAIDs associated with increased incidence of accelerated atherosclerosis and myocardial infarction. That is one problem. And second, NSAIDs increase the incidence of renal dysfunction, liver dysfunction, raised AST-ALT ratio. All these blood problems are seen with NSAIDs. However, paracetamol can have all this, don't have all these renal problems and MI, but it is less effective as an anti-inflammatory agent than NSAIDs. If NSAIDs are not effective, we can go for steroids. Namely, prednisolone 1 mg per kg can be started. And the other group of drugs will be the hydroxychloroquine. Hydroxychloroquine can be given a dose of 200 mg BD, but the problem with hydroxychloroquine is that you have to go for a fundus examination. It is notorious to cause optic neuritis. So fundus examination should be done yearly once. If other than that, hydroxychloroquine is a safe drug and it can be given in SLE patient. Almost all patients with SLE, it can reduce the incidence of renal involvement. It can reduce involvement in joint. The arthritis pain can be reduced. It will prevent the disease progression. The other group of drugs will be the methotrexate. Methotrexate is an antimetabolite, and methotrexate can be given at a started dose of 7.5 mg BD, usually given on Saturday and Sunday. The remaining 5 days, the patient should be started on folic acid because it is a rare folate reductase inhibitor. It should not be given in pregnancy. It is a category X drug in pregnancy. Non-pregnant patient can start the patient on methotrexate. Usually start at 5 or 7.5 mg, then uptitrate regularly. You should rule out HBV and HCV infection before starting this methotrexate. The liver function test should be normal, renal function test should be normal, HBV should be negative, HCV should be negative, HIV should be negative. Then you can start this drug, and it is also a highly effective drug for minor involvement. For just a patient with fever, myalgia and arthralgia, you can manifest with NSAIDs or HCG or methotrexate. That will be enough. If the patient is having dermatitis, you have to go for avoidance of ultraviolet radiation exposure. Then the patient should should apply skin creams, the sunscreen with the SPF of at least 20. They should use that, and the patient should go for topical steroids. If they are not effective, the patient can go for oral hydroxychloroquine can be taken, topical retinoids can be given, and the patient can give other drugs like mycophenolate mofetil, azathioprine, cyclosporin. They can be given in refractory cases. Nothing works, you can try thalidomide or dapsone, but they are notorious to cause peripheral neuropathy and fetal problems. Phocomelia is more commonly seen with thalidomide. This is how you manage dermatitis in SLE patients. What are the life-threatening organ involvement? Predominantly the lupus nephritis. Lupus nephritis is the most common life-threatening organ involvement that is seen in patient with SLE, or lupus pneumonitis can also be present. So how do you manage lupus nephritis? The main management in lupus nephritis is going for high-dose IV steroids. Predominantly amethylprednisolone 1 gram IV for 3 days, followed by oral prednisolone 1 mg per kg per day for at least 6 weeks, approximately 6 weeks can be given, and then it should be tapered to a lower dose like 10 milligram or something. Steroids are the first line of drug for inducing remission in patients with SLE. When the patients are not going for remission with only use of steroids, other drugs like cyclophosphamide or a mycophenolate mofetil can be used as remission. Mycophenolate mofetil is more preferred in Afro-American and Hispanic population, and cyclophosphamide is more prevalent in an European or Asian population. They will go for cyclophosphamide. Mycophenolate mofetil 1 gram, 500 mg PDR, 1 gram can be given, up to 2 grams can be given maximum. Cyclophosphamide can be given at 2 mg per kg dose infusion. Once the patient has attained remission with either cyclophosphamide or mycophenolate mofetil, then the patient can be put on maintenance with azathioprine or MMF, can be given as remission maintenance. And if nothing works, you can go for biologicals like rituximab and belimumab. Belimumab cannot be used in severe infection. Belimumab can only be used in FDA approval is only given for non-life-threatening infection with no response to other NSAIDs or HCQs and methotrexate. Belimumab can have steroids. Belimumab can be tried, but belimumab is very costly and not given in all patients. And rituximab is an anti-CD20 antibody, monoclonal antibody directed against CD20, that is predominantly used in when nothing works. As a last resort, rituximab can be given in these patients. The other drugs which can be tried can include the cyclosporin and the calcineurin inhibitors like tacrolimus. This can be tried when nothing works. This can be used as a last line. So management, SLE patients, non-severe, severe. Non-severe patients with no problem with this day-to-day activities, manage them with NSAIDs or methotrexate or hydroxychloroquine. You should manage with these. If the patient is having significant organ involvement, if they is having poor activity of daily living, you can start the patient on steroids or belimumab. If the patient showing signs of lupus nephritis or severe organ involvement, go for pulse methylprednisolone followed by oral steroids. If it doesn't work, you can go for induction with either cyclophosphamide or mycophenolate mofetil. Once the patient go for remission, maintenance can be made with either mycophenolate mofetil or azathioprine, and that could be you can add even low dose prednisolone as a triple regimen. If it's an Afro-American, go for a mycophenolate mofetil. If it's an European or an Asian, you can go for cyclophosphamide, low dose cyclophosphamide, 500 milligram, that will be given. So this sums up our discussion on systemic lupus erythematosus. I hope you liked my discussion. If you found it to be useful, I would like you to share it with your friends and your juniors or your seniors if you're an undergraduate. I would like you to share to subscribe to my channel and click the bell icon. Thank you.